Hello, Dr. Hyman. In room 1, we have Mr. J, who is a 35-year-old African-American male who arrived at the office today with a complaint of abdominal pain. The patient complains of severe, sharp abdominal pain for the last 3 months, which radiates from the periumbilical region up to the sternum, laterally to the right and left abdomen, and to the lower back. Today, the patient rates the pain as sharp in 10 out of 10 using a numeric pain scale. The patient reports worsening pain when lying down or after consuming food. Typical foods consumed in the last 24 hours include those high in carbohydrate and fat content. The patient reports having bowel movements once every 2 days. Consistency is soft, formed stools which are light brown in color. Attacks of abdominal pain are frequently accompanied by nausea with yellow-brown emesis. The abdominal pain has caused weight loss of 30 pounds over the last 2 months due to anorexia. Dyspnea, tachypnea, anxiety, and diaphoresis have been reported when the pain episodes occur. The review of symptoms is as follows. He currently complains of sharp abdominal pain, which is 10 out of 10 on a numeric scale. He is observed to be vomiting light yellow clear emesis into a trash can. The patient states he has not consumed any food in the last 72 hours. The patient's last bowel movement was 48 hours ago with soft, formed, light brown stool. He complains of current difficulty catching breath. He complains of substernal chest pain and a racing heart. He expresses fear and anxiety. The patient has a past medical history of recurring heartburn and has had a tonsillectomy at the age of 3 years old. The social history is as follows. He is currently unemployed, but has previously worked in landscaping. He is single and has 2 children, aged 8 and 10, whom he sees every weekend. The patient lives alone. He consumes 4 beers per day, 5 days a week for the last 10 years. He smokes a half pack of cigarettes daily for the last 15 years. He is Baptist and does not attend church regularly. He is also heterosexual. The patient has a positive family history for hypertension, hyperlipidemia, and hypercholesterolemia on his maternal side of the family. Hypertension is present on his paternal side of the family as well. He has no known allergies or intolerances. He currently takes Zantac 150 milligrams by mouth twice daily. His current temperature is 98.4 Fahrenheit, blood pressure 146/94, heart rate 115, respiratory rate 32, with an oxygen saturation of 97% on room air. He is a thin, malnourished appearing male with good hygiene. Soft palate appears erythematous without exudate. He is partially bent over with hands over abdomen with an unsteady gait. In the supine position, heart contractions can be visualized at Erb's point. Bounding carotid pulses are visualized bilaterally. The apical pulse is palpable at Erb's point. Normal S1 and S2 are auscultated without murmurs or extra heart sounds. Tachypnea, dyspnea, and a shallow breathing pattern are observed. Decreased lung sounds are noted in bilateral vases, both anteriorly and posteriorly. He appears anxious. The abdomen appears scaphoid and guarded. Hypoactive bowel sounds are auscultated in all 4 quadrants. Upon percussion, the abdomen is dull in all 4 quadrants, which may be attributed to muscle contraction and guarding. The abdomen is painful upon shallow and deep palpation in all 4 quadrants. Rebound tenderness is positive. Differential diagnoses include acute cholecystitis, appendicitis, peptic ulcer disease, pulmonary embolism, and acute pancreatitis. The patient will be referred to Spartanburg Medical Center for a CBC, CMP, CRP, fasting lipid panel, serum and urinary trypsinogen activating peptide, ultrasound of the gallbladder, CT scan of the chest and abdomen, KUB, and chest x-ray. A final diagnosis of acute abdominal pain will be made pending laboratory and radiology findings, which are yet to be done.